Hey, folks, we're back again with another edition of Great Minds in our community. We're very lucky to have one of my good friend and endocrinologist who practice in Pinellas County, and we're going to be talking to Dr. Budharaju pretty soon. But I want to appreciate you guys supporting our webcast for more than a year now, and we are still going strong. And someone, in fact, asked for expert on diabetes to come to our show. I think about a few weeks back. So on our viewer demand, we got Dr. Budharaju, and he was very kind to accept our invitation to come to this community talk on Facebook Live and YouTube Live, and we're going to be adding LinkedIn Live as well. So we are very excited to be on different platforms to get good information to our patients and our local community at large. For those of you who don't know me, my name is Dr. Mahajan. I'm a board certified internal medicine physician practicing in Largo, and we do once a month webcast, and we bring different thought leaders in medical community and other areas too of concern to our patients. So thank you so much for tuning in, and we'll give you a brief intro about Mahajan Medical Center, and then we'll get Dr. Budharaju on our webcast. At Mahajan Medical Center, we care to listen to our patients, proudly serving the needs of Tampa Bay in primary care for 25 years and counting. Thank you for listening to our intro. And I know the open enrollment for Medicare is coming October 15th. So today is October 14th. So if any of your friends or neighbor need a good primary care, please think about Mahajan Medical Center, and we do appreciate your referrals. So without further ado, let's get our guest today. He's a good friend and a fantastic endocrinologist. And for the lay people who don't know endocrinology, it's a field primarily, diabetes, thyroid, but there are other organs in the body too, like adrenals and parathyroid, as well as pituitary. So, Dr. Budharaju covers all those fantastic organs, which we normally don't know about till, God forbid, your sugars goes up or your, get pituitary tumor, God forbid, then we need their expertise. So let's get Dr. Budharaju on our webcast today. Hey, Venkat.
Hey, how are you, Ranjan?
Thank you for coming and accepting our invitation, to share your knowledge. So before we start, tell me a little bit more about yourself, where were you trained and how you got interested in endocrinology.
Well, yeah, before I start, I really want to thank you for extending this invitation into your wonderful program. And it looks like it's a great effort to improve awareness of all these important diseases in the community. And also appreciate your kind introduction. So I think endocrinology was one of my top passions because of my interest in numbers and how it ties in, how we can see objectively the changes that we make, and immediately the results are seen in front of us in terms of diabetes management and glucose control. And also my passion in nutrition and diet. And I think combining those two together was the foundation of my interest in endocrinology and metabolism. So I got started, I got trained in India, went to medical school there, went and trained in UK for a few more years, and then ended up in Philadelphia, Pennsylvania with the UPenn health system. Did my residency in internal medicine, and then went to wonderful cold and Iowa City, wherein I finished my endocrinology training, and then decided to come to warm and sunny Florida. And I've been here since for the past 10 years in private practice, in the community, and both inpatient and outpatient work. And it's been a wonderful journey.
Great. So, so you came from Iowa, Pennsylvania to warm Florida because you grew up in warm part of India.
That is right. That is right. I think for me, that has always been one of the important things to have in the quality of life. I'm an outdoorsy person, play some sport and enjoy the time off in the warm weather. And also, I think a couple of good friends were in Florida, and they really liked what they were doing and the impact they were making in these communities. So I thought I can have best of both worlds, and I couldn't be happier.
And your daughter is following in your footsteps. She is in UF and Go Gators, huh?
That's right. That's right. Yeah, I think I couldn't convince her out of this, I guess, and she has her own passions, and she wants to make a difference in the community as both as a leader and in education and healthcare. And no better field than this, especially for women. I think it's a huge blessing if they can be independent and make a big impact. They tend to be very empathetic, and she likes to contribute in social justice. And I said, why don't you combine that with your passion with science, and you can make a bigger impact in the community. And she's following the footsteps. So just started. So we'll see how that goes.
That's fantastic. It's good to see your kids grow and blossom, and makes your chest get bigger.
That's right. That's right. That's right. Yeah.
So let's get into the topic today. What percentage you would say your practice on day-to-day basis is diabetes?
Yeah, that is a very interesting question. I think it varies with the where we practice and the type of practice that we have. In my practice, I'm surprised to look at that I do almost 50-50 diabetes and non-diabetes patients. And talking to my colleagues and other practices, it tends to be a little more heavier diabetes. But I think it's just probably your interests and how you get a name for yourself and everything. So I do mostly 50-50, maybe a little bit more diabetes than non-diabetes patients. Then thyroid tends to be majority of what we do. And like you mentioned about the other fascinating disorders, including the pituitary, adrenal, PCOS, hypogonadism, those tend to, and then also calcium disorders, right? The parathyroid disorders
Right.
and bone disorders tend to be the rest. But they are certainly the minority, but they keep our intellectual engine going and keep us interested in what we're doing.
All right, let's dive into diabetes, the main player, and
Sure.
we'll find out why it's so important to know about it. Here we go. So this is the topic of interest today, and let's see why it's important. So let's get to the next slide. Okay, here we go. So as you can see, it's critical that we should know more about diabetes because 1 in 3 uh, Americans will develop diabetic or get diabetes by 2050. And the current data is 34.2 million people already have diabetes. And then, there is a category just below diabetes, the pre-diabetes, and that's 88 million. So if you do the math, that's massive. Do you want to comment on the incidence, Venkat?
Sure. I think the as you alluded, Ranjan, the way the trend is not very good. I think it is an important disease. It's always been a very very difficult disease to manage, very expensive for in terms of the healthcare resources that we it takes up. But if the current trend continues, almost 1 in 3 Americans will might end up having diabetes. And like you said, the pre-diabetes tends to be even bigger problem. Almost 1 in 2 might end up with pre-diabetes. So I think the big message there is to how it is the incidence or the prevalence of diabetes has doubled over the past 20 years, and how we need to really not only focus on managing diabetes but also preventing diabetes, wherein we understand the risk factors of diabetes. That includes pre-diabetes. So that gives us a very good opportunity to make a big impact earlier on, and then use the resources appropriately in management of this really difficult condition. Because if you look at the slide, it just does mention also about how their early death rate is almost 60% higher in patients with type 2 diabetes. The prescription costs are twice. So it's a very expensive disorder. It takes a toll on all aspects of the individual's mental and physical well-being. And the lifespan of many of these patients, once they develop complications like cardiovascular disease, stroke, kidney disease, is reduced by almost 5 to 10 years if they don't control this deadly disease earlier on. And as we know, diabetes is the seventh leading cause of death, and it is a leading cause of blindness, kidney disease, and amputations in the United States. So we cannot emphasize enough how important it is.
So let's just introduce our audience to different types of diabetes. I know the type 2 diabetes is what we see in adults and more prevalent. About 90% plus diabetics are type 2, and type 1, a lot of our listeners know, is early onset. You get in your teen years. And we're going to focus today, and because it's a big topic itself in type 1, so we don't have enough time. So we're going to focus today on type 2 diabetes primarily, which is the diabetes of adult onset, correct?
That's correct. So I think, like you mentioned, about 5 to 10% of patients tend to have type 1 diabetes, and 90 to 95% have type 2 diabetes. And type 1 diabetes being a unique disease in itself, that we don't have, although lifestyle and management of their diet and exercise is very important, taking insulin, which is mandatory in them. Type 2 diabetes tends to be more focused on lifestyle management, wherein you can
We'll
make an
come to
impact.
lifestyle later. I know that's
Right.
going to be the big part of our talk.
Right.
So
Right.
let's go into the pathophysiology a little bit. Let me bring
Sure.
the next slide up. All right. So do you want to talk about the pathophysiology, how the healthy pancreas is? And by the way, folks, for uninitiated, the pancreas is the factory for the insulin, the islet cells there, and that's what this slide shows. Do you want to talk a little bit more about the left half of the slide, the healthy, the type 1, the type 2? Venkat?
Sure. So diabetes, as we know, is a disorder of energy metabolism, right? So when we try to utilize the food we consume and convert to energy, and glucose tends to be the main source of energy. For the cells to be able to metabolize glucose, insulin is a key for the entry of the glucose into the cells. And if the insulin production, which is lacking in type 1 diabetes, or there is insulin resistance due to a problem with the receptor or the post receptor, there seems to be a problem with glucose utilization. As you can see, the red, those glucose molecules cannot enter the cells because either the insulin is lacking in those triangles, the purple triangles, or there is really some insulin resistance in type 2. So type 1 is where there is destruction of the pancreatic cells which produce insulin, and type 2 diabetes is where there is resistance to insulin at the level of the receptor or within the cell post receptor. So while these are the broad classifications and how we know, there is increasing interest on other types of diabetes, which is the type 1.5 diabetes.
Do you want to talk a little bit quickly about type 1.5?
Sure.
I know that's a little bit esoteric, but let's give something fun fact to the people who are listening.
Sure. I think it is important to know because so many of these patients are diagnosed as type 2, and they don't respond well, and they are frustrated, they get on oral medications. And the key difference is that they have antibodies against their own pancreas. So they have combined features of both type 1 and type 2. They can look like a type 2, but they are not. They're having antibodies against their own pancreas, and they usually are 30, 35 years old or above, so definitely adults, and they sometimes can manage their diabetes without insulin. So that's what people, many of the providers and patients themselves think they have type 2, but over a period of time, their insulin production will decrease and they might need to get on insulin. So the important fact is to recognize that although they look like a type 2, they are not type 2s. A distinct form of diabetes is also called as LADA, wherein they are not type 1 immediately at that point in time of diagnosis, but they can quickly get into decay and everything. So this is a very interesting part of what we do, is to identify these patients when they come to the clinic. They tend to be thin, and they are not responding to medications, and their A1Cs are high. So we check these antibodies in these patients, and then start them on insulin or very, very quickly to make them feel better.
That's a great point. Let's just talk a little bit about, diagnosis of diabetes. How do we diagnose? So for the lay
Sure.
folks, the diabetes is high sugar. So at what level the sugar uh, diabetes, we call it diabetes. So on this slide, you can see more than 126 fasting, or if you do the 2 hour postprandial, then it should be more than 200, or random sugar more than 200. And the third aspect is the A1C greater than 6.5. Anything else you want to add to the diagnosis of diabetes?
I think no. I think that's a good summary of the whole thing. I think obviously if there is less than that, then you call it pre-diabetes, right? Between 100 to the 126 mark is pre-diabetes. That's when majority of the patients in the community might find themselves. So, and then if it is 140 to 200 after food, then that's also considered impaired glucose tolerance or pre-diabetes. We combine all of things and call it pre-diabetes.
That's a good point. And let's quickly look at different organs. It's a busy slide. So do you want to just give a quick synopsis? What does it cover?
Sure. I think without spending too much time on this, like you said, we can speak for an hour on this slide, but but I think it's just I just wanted to open up this idea of for everybody that diabetes is not just a disease of the pancreas or the liver itself. It is, now we know that multiple organs are involved in the pathophysiology, including the kidney. We understand that there is also involvement of the neurotransmitters in the brain, which do not make us feel full, and we are hungry despite our sugars being high, our insulin levels are high, but we still don't feel full. And we find that there is some neurotransmitter dysfunction, there is increased glucagon secretion in the liver, and there is increased lipolysis, the fat breakdown, which leads to insulin resistance. And also there is this incretin, which is a fascinating concept, which we have figured out over the past few years, is released from the gut. So those hormones can play a crucial role in increasing the insulin after we eat. And if that is lacking, then we can get into trouble. We'll talk a little bit about the next few slides about some of the new drugs which can accommodate all these different mechanisms.
Right. So, it's a multi-organ disease, not just pancreas, as you just pointed out. So that increases the targets as well to improve the diabetes, which has exploded in the last 10 years. Thank God for that.
Absolutely, yeah.
And some of those drugs are magical, like the GLP-1 agonist. We're going to talk a little bit more. It has
Absolutely.
helped the patient lose weight. And so they work on different aspects of the diabetes. So, it's like cancer treatment now, Venkat, where you have multi-target approach to control your sugars, not just, like in olden days, we just had insulin and then just the sulfonylureas. Now, we have multi-organ targets to work with.
Absolutely. And we'll dwell into some of those in the next few
Right,
slides.
right. All right, let's go to the next slide. This is a busy slide. It talks about low sugars, and we'll cover that in a minute. It also talks about the effect of the high sugars on different organs. Do you want to start with the effect of the high sugars on different organs, then we'll talk about hypoglycemia quickly.
Sure. I think, as I just, again, this slide, the purpose of this, I know it might be a little busy and might not be visible, or the details might not be visible, but just to open up the idea about how high blood sugars can impact every single organ and organ system potentially in the body, and this slide, this picture shows not only the symptoms and signs, but also the complications. We all know how it can affect the heart, increased risk of stroke, the vascular disease, neuropathy, but also some of the skin problems that we face, and then the stomach issues wherein there is neuropathy. It can affect the stomach and it can cause gastroparesis, comorbidities like hypertension, how important those are in managing. So I think it's just give, and also the retinopathy and how it affects the vision, glaucoma, increased risk of glaucoma and cataracts, which can be premature in patients with diabetes, and increased risk of amputations and foot ulcers. And the symptoms, if you look at the symptoms and such, briefly touching on them, increased thirst, increased urination, and so those are the main symptoms. Weight loss sometimes, and muscle weakness, easily getting dehydrated, having a dry mouth, blurry vision, and tingling numbness in their feet. Those are the common symptoms. But what is most important to understand is that many of the patients who have diabetes do not know they have diabetes, and that is shown to be almost 1 in 5, which is a staggering number. And that's why they come very late, and they might have already had some complications. So it is very, very important to screen, and if you're at risk, to get your blood sugars checked, like a fasting blood sugar or a hemoglobin A1C, especially if you're at a risk for developing diabetes.
I think that's a very important point that, if we catch them early at pre-diabetic stage, the interventions can prevent end organ damage. So the key is to catch them early. And let's talk about risk factors while we are, at it. So then the patients know that they are higher risk. For example, I'll add few and you can finish the
Sure,
list.
sure.
If you have family history of diabetes, that's a risk factor for diabetes. And then if you are obese, truncal obesity is a risk factor. If you have a certain kind of ancestry, Hispanic, or if you are uh, Alaskan origin, or
Afro-American, yeah.
Hispanic is critical, and then Afro-American,
And
people of
Asian too,
color,
yeah. Yeah.
you know, Native Indian people have higher risk. Anything else comes to your mind, Venkat, which I missed?
I think minor ones. You covered all the major ones. I think the minor ones would be, obviously, if you have pre-diabetes, then you are at risk for developing diabetes. If you have in women, and especially younger women, if they have polycystic ovarian syndrome, they tend to be a little higher risk. And fatty liver is also a fascinating precursor, has been found for the whole metabolic syndrome and diabetes. Women who have developed gestational diabetes, they tend to be at risk also. And what is very, very interesting is the ADA also puts in sedentary lifestyle. If you have sedentary lifestyle, which many of us do, especially in this virtual Zoom era of ours, that is an independent risk factor in itself. And you don't have to be obese. If you're overweight, and like you said, visceral adiposity or truncal obesity, and you're sedentary, you already have two risk factors there. So I think it covers a lot of people. And as we talked, this could be 1 in 2 of Americans.
I think this, as you brought up COVID and the virtual, we're seeing younger kids, you
Absolutely.
know, getting type 2 diabetes, which is kind of, we think they will have type 1, but they're getting type 2, which is sad.
Right.
So I think community education about activity and exercise, and more healthier eating habits, which will come to later on, is critical in preventing pre-diabetes and type 2 diabetes, as it could be preventable disease. So finding it early, and giving enough education to the community, like we're doing on this forum and other forum, and EDA does that too, to tell them to get an annual physical. If you're pediatric age group or adult age group, go once a year. You pay for the insurance premium, at least get your fasting sugar checked. And as you rightly pointed out, if they have gestational diabetes, then get a A1C once a year if you're a woman,
Right.
and you had gestational diabetes. So I think people don't realize that there are patients who, by the time they come to us, they come in diabetic ketoacidosis.
Right. Right.
And
Right.
by the way, that's a serious condition where your sugars are very high. And we see primarily in type 1, but we're seeing in type 2 as well, and type 1.5 as well.
Right.
You don't want to get to that point. You want to, if you're losing weight, as you pointed out early, and you don't have a cause, or you're not trying to lose weight, and your urine is kind of, smelling kind of funky, and it's kind of musty, that means you're losing a lot of sugar in your urine, and you're getting frequent UTIs or urinary tract infections. That could be another tip for you to get your fasting sugar checked. You want to add
Yes.
something? I'm sorry.
Sure. No, I think I was going to say one of the things I've noticed seeing these patients with ketoacidosis, and like you mentioned, for some reason they tend to have an increased uh, desire to have sugary drinks, which is really fascinating, isn't it? Because they have high blood sugars, they have diabetes, they don't know that, and they're constantly drinking, Gatorades, juices, watermelon. They like watermelon, and they just don't understand. And they once they are diagnosed, they're, oh, that's what was going on. So that is kind of very, very interesting presentation. And you mentioned about the ketosis prone type 2. So you don't have to be a type 1 to get DKA. And there are other types of diabetes we didn't touch upon, which I think I'm sure will come up during the discussion, is if they have any underlying pancreatitis, either alcoholic or non-alcoholic pancreatitis, or if they have taken steroids for a long period of time, or they're on some immunosuppressive medications. So there's a lot of different types of diabetes which don't come under the umbrella of type 2 or type 1.
That's a good point. Let's go back to the busy slide. And you brought up a other very important topic, especially in seniors, Venkat, with hypoglycemia. The lot of organization, the American Society of Endocrinology, American Diabetic Association, is getting concerned that over aggressive, over jealous treatment of diabetes, and especially in seniors, is causing hypoglycemia, and that itself has high risk of getting strokes, coma, heart attacks. You want to touch a little bit about in seniors and hypoglycemia a little bit?
Sure, absolutely. Yeah. Seniors and hypoglycemia, and because I do some hospital work, I see this fairly frequently, unfortunately. And it's some medications with combination with the fact that they're not eating, and they get sick, and they continue to take these medications because they were not educated about. Sometimes they're taking 10 or 15 medications, and they don't know what to stop. And if they continue, especially the sulfonylureas, which we'll touch upon a little bit, are inexpensive medications, old medications we've been using, and they're still very useful. But those are the ones which tend to be the main, I would say at 80-90% of the time, the main culprit. And if they don't recognize this, a fall with hypoglycemia or a syncopal episode with hypoglycemia can be devastating, including fractures and head injury and everything, and the worst situation, or a hospitalization or a ER visit at the minimum, which is very, very troublesome for the patient, their family, and it puts them back. And equally important is the fear of hypoglycemia. So if they're fearful of hypoglycemia, then they tend to accept very, very high blood sugar readings. So the ADA has now pushed us into this idea of individualized approach. And it's not like one size fits all, that, oh, everybody has to be at a hemoglobin A1C of 6.5 or whatever the ACE goal is, or 7, which is the ADA goal. But we should target that to the patient, their situation, their motivation levels, goals, and comorbidities, and where they stand right now.
Okay. I think hypoglycemia is critical, and I think you brought a great point, Venkat, that you'd start chasing your own tail, because you take the long-acting insulin at night, and then you wake up, hungry.
Right.
If you still have the trigger, some people lose that trigger of warning them of hypoglycemia as they get older. So that's another reason to be very careful not to overdo on being too tight with especially long acting insulin, because then you, as you said, fear of hunger, and then you overcompensate, and then you go on to the hyper side. So probably err on the side of giving a little bit less, and loosen the control in the seniors, as they don't have as good alarm systems built in their body. But now in this day and age of triggers, we have CGMs which trigger it too, but it's not
Absolutely.
good to wake up middle of night anyway, whether
No,
it's your
nobody
home
likes that.
alarm.
That's the worst feeling that anybody can have.
Right. All right, so let's talk about next slide. I know we got a lot of ground to cover. So this slide talk about the correlation between your A1C and where your sugars are. So for example, 7% A1C correlates with 154 sugar ballpark. And then, the target for American Diabetic Association is 7 to 130. And if we can, after meals, get to 180, and then you got a nice graph here, where you want the A1C to be. Anything you want to point in at this slide, which
I
our
think
audience
a
should
couple
know?
of just a couple of points. One is the peak. I think I would like to, just I tell my patients also about the peak. It should be like 2 hours after. You should not be checking immediately after the food. Yeah, that tends to make everybody very nervous. So I ate, I checked immediately. It was like 190, and is that okay? So they have to wait for it to peak. So that's 2 hours. Is 1 to 2 hours is what we recommend. The second thing about the graph you mentioned was to show where we stand in terms of diabetes control. So that graph shows that only 54% of our diabetes patients are at target of less than 7%. That's sort of a snapshot of glycemic control that almost several patients, almost 14 million patients were in that study, and we are not doing a great job. Okay, it just shows that we still have a lot of room to cover. We need a lot of involvement of the patients' families and new drugs and these kind of educational efforts to get to our target of at least 80-90% of our patients with diabetes get to less than 7%.
That's a great point. I think earlier we start the education process about lifestyle changes and taking the medication on time, and the other piece we face in primary care, I'm pretty sure you face in endocrine as well, is the cost of the insulin too.
Absolutely, absolutely.
And that's a serious deterrent for compliance, and they, especially seniors, on limited income.
Hmm.
And the Walmart, will talk about that, has a good program, and we'll come to, when we come to insulin, we'll talk a little bit more. let's
Sure.
let's talk about the pillars of success, in terms of diabetic management. So it got cut off a little bit, so I'll help the audience. So healthy eating is number one, being active is number two. So we didn't start with medication, as you folks noted. We started with lifestyle changes. In my opinion, that should be always the first two. You should talk about what you put in your mouth, and then whatever your level of comfort is, if you can get a little bit more active than that, that will help you bring your sugars down. Healthy coping, and we'll touch on that. Monitoring, we'll touch on that. And medication management. Anything you want to point out in these skill sets?
No, I think, like you said, where you start and where you focus on is very important. And as the picture shows, they all work together. So if you miss one piece, the whole thing can fall down. Is the important message there?
All right, so let's talk about the key part of our talk, is the lifestyle. Let's elaborate a little bit more what we mean by a healthy plate for a
So this is
diabetic.
so this
So,
is a very. Go ahead, Ranjan.
okay, no, I just wanted to point out a key part of the healthy plate is
Sure.
right here, water.
Yeah.
you know,
Yes.
a lot of time we focus on here. I tell my patient, focus here
Right.
and here, and then if you have time left, or appetite left, then go here. So
That's
if
right.
you start with a big glass of water and a salad and a fruit, and then go other way around, I think it will help you keep your weight down, keep your sugars down. um, you go ahead with your rest of the pieces of advice you want to bring up.
Sure. No, I think you brought up a great point. Yeah, I didn't really think about it that way, but you're right. You can start with basically that and come from the left to right. But I think I just wanted to point out this is a very simple way of, you can start doing your cups and measuring and all kinds of different things, but it can get very difficult. This is a very simple way of doing it. What you put on your plate, and like you said, focus on the left hand side, get as many veggies as you can, preferably non-starchy. As it says, potatoes and french fries, they don't count as vegetables, nor does corn or other starchy veggies. And add a lot of variety and different color. And once you fill that up, then you go into whole grains for a quarter of your plate, and then healthy protein. If you're a vegan or a vegetarian, you can use vegetarian protein, otherwise animal protein, but preferably more plant-based than animal-based because of other benefits that we're going to get into in the next few slides. But this is a completely different paradigm from what we had from the US, the recommendations about 10 years ago, 20 years ago, where carbohydrates were the main foundation of the plate. So I just wanted to highlight the big shift and how easy it can be to do what we do every day.
And let's talk about the modified food pyramid, which I think is fantastic. So as you can see at the bottom is drinking water.
Right, right.
So that should be the base of your pyramid. And then go on the left side, variety of color, what I call rainbow diet. You add all the colors of the rainbow in terms of your salads, and the red starches, like instead of white potatoes, if you have the
The
sweet
sweet
potato,
potatoes, right.
and carrots and celery. Start there. And I have a patient who travel a lot, Venkat, and he's a diabetic, brittle diabetic. So he was
Hmm.
saying, I travel, what should I do? I said, when you go to a restaurant, the first thing you should say is, don't bring bread. And he said, what? I said, yes. If you tell them not to bring bread, bring water and salad. And with the salad, tell them to bring non-creamy dressing. Bring a
Yeah,
vinaigrette dressing or something on the side, not on top of the salad. I just start from there. Even
right.
in a restaurant like McDonald's, for example, not a great example, but even you're in a pinch. I have a lot of truck drivers who say, hey, how do we do it if they're diabetic? I say, if you drive into a McDonald's, start with a big glass of water and a salad and apple slices, and they sell you all that.
Right,
And
right,
then if you have space left, then get whatever you want. But you won't have a whole lot of space left. And eat slowly. Don't gulp
right.
it down. And don't get sugary drinks. Once you
That's
get
right.
sugary drink, you're pretty much the triangles, the Mediterranean diet, everything goes out of the window,
I
because
know. That's right.
you're not going to feel full,
Right.
and you're going to eat more on top of the sugary drink. So let's go back to the Mediterranean triangle you brought. And you want to point out the daily and the weekly piece here.
I think yeah, you covered the kind of the most important points. I think as we go on to the top, if you as you can see, you can have certain stuff like animal protein and everything, but it has to be like limited. It has to be like a weekly thing, almost like an 80-20 kind of principle, wherein you do 80% of the time you're on the bottom, mostly fruits and vegetables, some whole grains, whatever you like. And of course, people modify this to their own likings. If they want to do a keto diet, they can really go very, very low on the carbs. Because mostly, I think the main principles of diabetes diet, in my mind, are having low carb diet, right? And then on top of that, you add uh, certain small pieces of whatever you like, in terms of whether you want it plant based, and then what kind of fats do you introduce, and we'll touch that in the next few slides a little bit. But I think the Mediterranean diet probably is the most balanced diet. I've done a lot of reading and research into this, and I feel like most of the data suggests that Mediterranean diet is not only good for diabetes, but also for blood pressure, for heart disease, cancer, and dementia. So all the big pieces are touched by some form of modified Mediterranean diet, and you can add and remove certain pieces at the top.
I think that's a great point you bring. People, and we have this recurrent theme in our podcast and webcast that we touch on plant-based diet. And I have oncologists come in, Venkat. I have
Right.
nephrologists come in. I got
Right.
neurologists come in. Now we have
It just shows.
endocrinologists come in. They all
Yes, it
bring
just shows.
Mediterranean diet, and I don't
Right.
prompt them.
Right. 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 It just shows that you don't really don't need any more proof than this.
Yes. So the oils you mentioned on the slide is critical. Try avoiding the oils like peanut oil, or try having more polyunsaturated fat like olive oil, and have small portions, but if you sprinkle directly on your salad instead of frying it, then you get more value from it. Once you fry even the olive oil,
Right.
you lose the advantage. But if you have to, just do baking or broiling instead of frying if you can. And frying does make it tastier, as you said, 80/20, 80% time if you can broil and bake, and then 20% time if you want to, you can. Air fryers are becoming really good too.
Yeah. Yeah. That's true.
A little bit of oil in the air fryer, you can still get the flavors, and still maybe have sweet potato fries instead of baked potatoes fries, and that to make it yourself.
Right.
If you go to a fast food restaurant, you get the fries, you're going to finish the whole portions, and that's quite a big portion. Then you have to
Right.
skip your dinner.
Absolutely. Absolutely. And you're done for a couple of days after that.
And you don't feel good after
Right.
that too. So
Right.
and then meat products. I think people grew up with meat, and it's very hard to change their thinking. And I'd say, okay, just do meat free Mondays.
Right.
Start with just one day of the week, skip meat, and you will see that your sugar levels, your risk of colorectal cancers, and then WHO came up with a big report now that skipping meat once a week will help us reach better goals with methane production too.
Yeah. Yeah. And if you look at the community and the earth, yeah, so
The
definitely that's
biosphere,
right.
so a
Right.
little bit less meat. I'm not saying zero meat, and maybe once a week is good. Let's go to the next slide. Do you want to add anything, or
No, I think that's great. I think we'll touch
okay?
upon many of these in the next few slides. So let's keep moving in the interest of time.
All right, so let's talk about the next big topic, exercise. And it's everyone's favorite, and it's difficult if you are not an exercise kind. But the least is 150 minutes per week if you can do it. And some of the seniors listening to our show, they have arthritis, they have different limitation to doing the exercise. So what I tell them is something very simple. I say, whatever your capacity is, add 5 more minutes to it.
Right.
Everyone can add 5 more minutes to their capacity. So let's say you walk with a walker. Fine, you can't run, but add 5 more minutes to your walk. So, and then add 5 more minutes after a month. So by the time a year comes around, you'll be doing 30 minutes, and you'll have less falls. Your sugars will be better. Your less hip fractures. And it will help you with your mentation, make you have more endorphins. So the exercise is again the recurring theme I get from every specialist we
Right.
get on the show, other than the plant-based diet. You want to
Sure.
add something, Venkat?
No, absolutely. Yeah, this is obviously not anything new. That this is we know all of this. Like you said, how do you tailor this to your own needs and not get too worried that, oh, I'm not doing the 150 minutes a week, or I'm not doing aerobic exercise on the treadmill or elliptical. But like you said, how do you just increase your physical activity? Like just walking, walk until you throw a sweat, or some sort of stretching, and whether you do, and we will get into a little bit of meditation, yoga, and that kind of thing. But if you come, I think the best way to do it would be to combine two or three different types of exercises, whatever you can. Obviously, going to the gym helps if you can, and having a personal trainer if you really can afford that. So all those things will keep you on target. But I just wanted to point out how it is important to combine a few different forms of exercise so that you can hit the aerobic capacity and also the muscle resistance and everything with the skeletal muscles.
Right. And, a lot of seniors are on Advantage plan, Medicare Advantage plans.
The silver
And they,
sneakers, yeah,
they provide either Silver Sneaker or something similar,
right,
and which is free. And, the amazing part about those programs is they can join more than one program. So they
right,
can, if they like the water aerobics, let's say you have arthritis or issues of balance, then you can do water aerobics, let's say at LA Fitness, and then, do a group class, somewhere else, where they do a good group class for seniors. So, and then you can do a Tai Chi at another center. So you can mix and match, and Silver Sneaker is fantastic. It's just that you need a partner, and I
right.
always encourage, patients to go with a partner so they can push each other. I think that then they can maintain their goals for exercise.
Absolutely.
All right, let's talk about yoga. I know you're a big yoga fan. I'm a big yoga and breathing exercise fan. How does it correlate with the management of diabetes, Venkat?
I think, just the slide, I just want to point out how it affects both the body and mind, and specifically looking at the insulin secretion, how it is very hard to imagine, right, how yoga practice can increase insulin secretion. And studies have shown that time and again, that it increases insulin secretion, decreases insulin resistance, and also decreases the sympathetic drive. So our stress levels come down, so cortisol levels will come down. So you would see that your insulin, whatever you make and whatever medications you take, if you're on medications, will be more effective. And of course, it improves your quality of life and mood, and helps your all the other parameters which are associated, including the body weight, blood pressure, heart rate, and lipid profile. So I think this one thing, if you can, if like you mentioned, with all the limitations that our seniors have in terms of doing vigorous exercise, this is certainly something which I think we'll increasingly see, not only for people who are yearning to have peak performance and clarity of mind and everything, but also for patients with comorbidities, including diabetes, to get better.
That's a good point. Let's talk about different types of carbs. I know that's your favorite topic. You get from your patient what are complex carb, what are simple carbs. As you can see, the complex carb on the left panel is the potatoes, rice, pasta, bread. And the simple carbs are sugar, honey, syrup, fruit, dairy. And you can get your higher amount of sugar from both sides, whether it's complex or simple. You got to pick complex if you have a choice. And then again, less white it is, better off we are. So if you can pick, as I said earlier, a sweet potato instead of the white potatoes. And if you're going to go with a pasta, go with chickpea pasta or vegetable pasta instead of refined flour pasta. And same thing with the rice. We get a lot of Asians in our practice, a lot of South Americans, and they have beans and rice as their staple.
Right.
And I tell them use brown rice, and then I started adding, in addition to brown rice, quinoa in my diet. And I think that's another fantastic grain which you can add to your salads, to your stews, to your beans. And if you pick more fruits here, again, the fruits, if you pick fruits, don't eat too much grapes or strawberries, but some is okay and better than refined sugar. If you're going to have sugar, maybe a little bit of honey or a little bit of brown sugar is better, because I tell one thing to all my patients, Venkat, is anything slow is go. And they ask me, what do you mean? I said, if you, for example, have oatmeal, if you have a quick oatmeal, it's pure sugar. And
Right.
if you understand this concept, I think most of the diabetics will make good choices, because the quick means there is no fiber.
Right. Right.
So that means it takes quicker to cook. And if you have fiber, it's like extended release medication. It does
Right.
not allow the sugar to escape quickly, and that allows your body to cope with the sugar coming out, compared to, let's say, soda pop or ice cream or juices. Your sugar goes up very quick, and there is no insulin, there is no wherewithal the body has, and then you get into more trouble. You want to add something more?
Yeah, sure. I think the concept you mentioned is called glycemic index, right? So Glycemic index is how fast your sugar increases after you consume any food, and it is compared to glucose, which is considered to be the highest or the benchmark. And compared to glucose, which is simple table sugar, how the food rises, how fast the sugar rises is what's called as a glycemic index. And we know the higher the worse, right? The lower the better. And like you said, anything which has fiber, there's also a concept called net carbs, right? If you delete the amount of carbs and you remove the fiber from it, then you get net carbs. So if you have 45 grams of carbs, and we'll look at a label in a second, and you can remove that fiber, and you have less net carbs, because fiber really slows down the absorption of the sugar and lets the insulin catch up with the glucose, so that the sugars will come down slowly and steadily and not have these big spikes.
That's a good point. Let's bring some comments from the audience here. Beth is saying that very informative. Thank you, Beth, for watching our webcast. That's very kind of you. Deanne Fink is saying, I agree with exercise and sleep. And I think she brings a good point. Let's talk about sleep. I think that's critical too, to get good REM sleep, to keep your sugars tight. Do you want to talk a little bit more about sleep and the effect on the sugars?
Absolutely. I think, about, I would say 80-90% of my patients, when I talk to them about weight, they talk about diet, how low calorie, low carb diet, they're little not eating anything. And they exercise like whatever they can. They're just going to the gym, personal trainer and everything. And they talk about stress, and we talk about that a little bit. But then when I hit the word sleep, that's when they have an aha moment. And I ask them, okay, how much are you sleeping, and what's the sleep like? I barely sleep 4 hours a day, 5 hours a day, max. So I think sleep has a big correlation with weight, and as a result, all the other associated problems which come with weight, including diabetes. And obviously, I'm sure you see a lot of this a lot. So I think any focus, that's where the practice like yoga, exercise, meditation, and just trying to have a community along with you, working with a community wherein you can, like a Facebook group, or some form of community you have, will help a lot cope with this illness.
Right. So, it's a complex disease. There is no simple answers, as you are pointing out. It's involved multiple organs. So other thing I tell my diabetics, I'm pretty sure you tell your diabetics too, is it's a marathon. Maintaining diabetes is not a sprint.
Absolutely. Right.
So don't get overwhelmed that I need to change the diet, I need to change my exercise, I need to improve my sleeping pattern, I need to drink more water, I need to take my medication. Yes, all
Right.
that is important, but start with one step.
Right.
Add 5 more minutes of walk. Everyone has these Apple Watches now. I don't have Apple Watch, but everyone has some form of Fitbit or Apple Watch, and just set up a simple goal. That I'm going to walk 2,000 steps a day. Start with that. Start with, not worry about what you put in your mouth. Start with just adding 2,000 steps a day. Just take, park your car away from your office or your, hospital, wherever you work, and take that extra steps instead of parking right next to it and go 10 times looking for a parking.
Right.
Let's start with that, and takes, staircase. If you go to your office and if it's safe and it's clean, take a staircase instead of elevator. So now
Absolutely.
you're combining exercise as part of your daily routine. And if you do that, then you will stick with that kind of routine, and it's become part of your daily habits instead of finding time for gym. So I think just doing that, I've seen, will lead to you picking better choices when you go to a restaurant, because you say, "Gee, man, I'm spending 3,000 steps. Let me not have the bread now."
Right. Right. Yeah. Only they're all linked, isn't it?
Right. Let's talk about the other key nutrients. I know we got a long topic, with diabetes. Do you want to point out on fats and protein what you're trying to show here?
Yeah, I think just wanted to show the different components of your diet and how we need to differentiate go into the details. It is not just about the macros, but because a lot of people say, okay, how much protein, how much fat, and how much carbs, but it's also the type of carbs, right? And it's also the type of protein, and it's also the type of fat. So we all know not all fat is the same, right? We want to look at, like you said earlier, the polyunsaturated fatty acids, and you want to get your essential fats in your food from healthy fat, so to speak. Probably the most difficult thing to do. And like you mentioned, more olive oil and more vegetable oils than saturated fats. And the protein, I think, like you mentioned about the resurgence, so to speak, about the plant-based diets in general. So I think a lot of push towards that. And if the patients want to, if it is a choice they would make, then I think going predominantly. That's why I like to call it a plant-based diet than a vegan diet, because you don't have to be a vegan strictly to get all the benefits that you need.
All right, so let's bring this slide up. That's a great slide you have. So, if you're looking at healthy fats, then almonds in the nuts category, I won't say peanut is a healthy nut, but I'll put in the end.
Right.
Cashew too, maybe more walnuts, almonds, pecans will be my first pick, and then
Sure.
cashews and peanuts. They're a little bit more
Probably the
fatty, but
last. Yes. Yes.
but still better than eating anything else.
Right.
uh, Vegetable oils, you mentioned that, so skip that. So the butters from the, again, moderation, because they still have a lot of fat, so but better than putting, let's say, anything else on your toast. Avocado toast are in fashion. I think I'm a big fan of avocado. It's a good fat. It helps your stay full. And the fatty fish, the salmon, herring, trout, and seeds. So seeds are very important if you can add to your salads. And stay away from this class of fat: the red meat, the full fat dairy, the tropical oils, the lard, the fried food, especially the fast food kind, and the baked goods, processed snack food. So the one thing I tell my patients on day in, day out, and we have a lot of diabetic, unfortunately, in our primary care practice as well,
Right.
is that when you go shopping, go with a list. Make a list of what you should take, because if you go in a grocery store, they're very clever. they they put all the, buy one get one free cakes, and everything which you should avoid as diabetic is right in front of the grocery store. They
On the
put
sides,
the
isn't it? On the other sides, yeah. Not in the, yeah. Yeah.
in the layout, they push the produce section way back. So I
Right.
tell my patients, a, the produce is more expensive in the grocery store. I said, go and support a local farmers market, and get your first stop at a farmers market, and fill up your shopping cart there first. So now you took a hit of 50, $60. You say, shit, let me skip the canned good and frozen goods, or ice cream tub, or cookies, anything which comes in a bag, give it to the person you don't like.
The
Anything
process
which
stuff. Yes.
anything which comes from a plant directly, eat more. Anything made in a manufacturing plant, eat less. And
Right.
if you go with that simple concept, in my opinion, and I think people don't talk about the effect of fructose syrup, how it causes type 2 diabetes in this country. Anything
Right.
with fructose syrup, and you have a slide on labels, will come to that,
Right.
is not good for you.
And
So,
it is
do
in
you want
everything.
to
It's in
add
everything. Yeah,
something
that's the
else to it?
problem. No, absolutely. I think you hit the major points there in terms of how to do the shopping and how to not to go. I mean, even if you're a simple thing like Publix, like you said, the produce section, I was thinking when you're talking is it's at the end. You have to go all the way around. So this label slide is very important, and I think the one thing which is probably missing in this is the ingredients. Also, looking at the ingredients and how we need to look at what's in there and not just the big categories. All the food manufacturers are mandated by the FDA to put all these things. So we should really look at the carbohydrates, and also don't miss the sugar section. how many added sugars are there. And we were talking about the fiber earlier on and how much fiber is in there. So per serving, I think if there is at least 5 grams of fiber, that'll be an excellent uh, food product for you minimum. And then if it has around 5 grams of protein, that'll keep you full. And then of course the amount of carbs that you need on top of that. And look at the saturated fat. How much saturated fat is in there, and what it should be. Obviously, less than 10% of your total fat consumption once you do your total fat intake that you require. So those are the things. And like you mentioned about the ingredients, and you should look at the each and every ingredient if you can, and avoid any additives, preservatives if we can, including the high fructose corn syrup, aspartame, or any other additives which can be a problem.
My mom came from India, I think, first time to the United States, I think 20, 25 years ago. And I took her to one of the grocery stores, the mega stores, and, she looked at one product. It was saying sugar free, and there was host of different products. I think she went to the diabetic section and everything was sugar free. So
Right.
she didn't know, they don't have big stores like this. Now they do in India, but at that time they didn't. And they used to get, people coming to their house and delivering the goods. Even in big cities, they have hawkers coming with vegetables and fresh vegetables. So they don't get as much packaged goods then. Now it's changed there too.
Right. Right.
So she asked me very quizzically, Venkat. She said, "Is sugar free and sugar free?" And it stuck to my mind that a lot of patients, they pick up the cookies sugar free, they pick up the cake sugar free, they pick up the ice cream sugar free. What they're not realizing, and they end up eating more thinking it's sugar free, that it's the calories,
Right.
which is still coming with the portions. So yes, you can have sugar free, but portion is where you got to look at. The sugar is free with that.
Right. That's right. You're right about a lot of people ask me, and that's the most common question I get in the clinic is, what should I eat? Right? What can I eat? What should I eat? And they talk about the choices they make, but very few people talk about the portions, right? The portion sizes and how many times they eat and how many times they're snacking. And I tell them that you don't have to have 3 meals a day and 3 snacks a day. It is not necessary. And this intermittent fasting concept is really growing, and a lot of patients are taking advantage as long as they're not on insulin or medications that can cause hypoglycemia. Apart from that category, I think the benefits of intermittent fasting, as you know, are really showing up more and more. And they can have carbs in a certain window of the day if they want to, and like you said, control the portions and eat a healthy, balanced diet.
All right, so I think we covered a lot of areas, and most of the fruits are Mother Nature's candies. If you're gonna have a sweet tooth and you want a dessert end of the your meal, go towards blueberries, or maybe have any of this on this plate. Some of the higher sugar content, if you're gonna have in moderation. The grapes, the mangoes, the pineapples, the cherries, and especially avoid pickle or canned fruits, that has very high sugar syrupy content or preservative. If you're going to eat, these are better to eat in a little bit more quantity, the blueberries, the strawberries, the kiwis, and the grapefruit. But if I am given a choice between a candy and a mango, I'll pick a mango. It comes with fiber, it comes with vitamin C. Candy only comes with sugar.
That's right. That's right. You're right about that. And I think this is probably the second most common question I get is fruit. Because when I mentioned that you should not be eating certain kinds of fruits, almost every single one of my diabetes patients is in shock. Oh, grapes are not good for you. Bananas are not good for you. Who doesn't have a banana, right? With their breakfast. Pineapples, some of them mangoes, a few. Watermelon is a big one. People love watermelon, especially many of my diabetics are like almost in tears when I mentioned that they cannot have or as much watermelon or grapes and stuff like that. So it's fruits are for if you don't have diabetes, like you said, it's a great choice between candy and fruit is always much better. But if you have diabetes, unfortunately, the fructose in these fruits gets converted to glucose eventually, and it creates the same problem, if not more. So you have to make healthy choices, and you should have more vegetables than fruits and have different kinds and more with fiber. Berries are great choices, like you mentioned, pears. Apples are also moderately okay, I think. And oranges could be great because of the fiber and vitamin C that they have.
I think that's great information you shared about different kinds of fruit, Venkat. So thank you. Let's talk about the big kahuna in the room. What should we do? If we have diabetes, someone has been diagnosed and the sugar was 200, they came to your clinic, they're losing weight, they are peeing too much and they're getting thirsty too much, and you made a diagnosis of, let's say, type 2 diabetes. Let's keep it simple. They're obese, they're not as active, and their mom or dad has diabetes, so our typical patient. So what we do from there? So what's your go-to medications to start with? Let's say obese type 2 diabetic, Venkat. We got metformin, my favorite one. A lot of myth around metformin G. It causes kidney failure, and I tell
Cancer,
patients that
yeah, yeah,
that's
yeah.
that's not true. Yes, if they have kidney failure, we don't want to use it, but it does not cause kidney failure. But the internet, unfortunately, has pushed a lot of myth. In fact, metformin, I read a study about, I think, a year ago. If you use it, your life expectancy goes up, and you can get free at Publix. I don't know if many drugs you can get free, which increase your life expectancy. What's your take on metformin? Let's start with that. Now it's an orphan drug. No one is pushing it.
Sure. No, absolutely. It is still my first. I always ask, of course, when patients come to me, by the time they come to me, they've already been on metformin, or many of them have stopped metformin due to because of the GI side effects. But I always ask myself and the patient why, if not if they're not on metformin, why they're not, and they always try to add it. The kidney failure is not a concern in patients with normal kidney function or even moderate kidney disease. They can still take metformin, and it is a great drug to sensitize insulin, and it can also lead to, and it does not cause weight gain for sure, and very rarely it causes hypoglycemia on its own. So it's a good drug and still the number one choice according to many of the associations. But like you said, recently there's been some concern about some forms of extended release metformin having some carcinogenic effect, and that is exclusively to one few brands of extended release metformin. So there's no reason to panic. And nephrology colleagues, many of my nephrology colleagues and cardiology colleagues, they want to keep metformin as much as we can, except, of course, when they get really sick or they're getting a contrast examination or they're dehydrated or they're in the hospital, they're having a procedure, maybe they should hold the metformin for a short period of time. But otherwise, an absolutely important ingredient of my list.
Right. So metformin is, the number one prescribed drug throughout the world for this reason in obese diabetic, because, for obvious reason, it's cheap, and it helps, at least, with some weight loss, not significant, but at least it's not putting on weight, which we're going to go to next class. The sulfonylureas, that's a big problem with weight gain in that class. And the other advantage of metformin is it does not give hypoglycemia. So I think that's huge as well in certain patients, that they're not chasing their food and staying hungry. Especially with sulfonylureas in older patients, especially with kidneys not working with long-term diabetes. Sulfonylureas, we get worried in older
Right.
patients.
Absolutely.
Yes. So let's talk about sulfonylurea. Still a great class of drugs, glipizide, glimepiride, or glipizide, ER or XR. They are a good class of drugs, but older class, and still useful to add on to maybe metformin, or maybe not, depending on patient type. But still a good drug, but weight gain is a concern, so you got to balance it out.
Sure. Well, I think the one thing is I want to point out is glyburide, which is especially in our elderly population. I think that is almost contraindicated in my opinion, and I think some of the geriatric societies have also put the drug in their warning lists that we should be trying to avoid. So I do suggest that if the patient is on glyburide, they try to switch to the to glibizide or maybe even glimepiride, and glibizide being a little bit of a better choice than glimepiride in my opinion. But both drugs are fairly good, and like you said, they still have a role to play in situations wherein the other drugs are expensive and they control blood sugars. They're very strong drugs, but they're not as effective down the line. You have disease for so long, and they can cause hypoglycemia and weight gain.
All right, so let's talk about the newer classes, the Dp4 inhibitors, the Januvias, the Truzenta and Glyza of the world. They have definite role, and there are newer indications coming for these drugs. But the weight is always a concern with them. Where do
Yeah,
you? Yeah.
the DPP4s have really were the next big thing, weren't they, at one point about 10 years ago because of the hypoglycemia, lack of hypoglycemia risk, and they're fairly weight neutral. But I think, again, this class of drugs is fastly becoming less and less commonly used these days because of some association with heart failure with some of these drugs, especially, I mean, some of these drugs have been shown to increase the risk of heart failure hospitalization. So, although an effective way to control blood sugars, they still tend to be a little on the expensive side. So I see that the DP4 drugs being squished in between the newer drugs, which we'll talk about, the GLP-1 receptor agonists and the SGLT2 inhibitors, and the older drugs, which is metformin and SUs, and maybe some pioglitazone. The DP4 is getting very, very narrow in where we can use them.
All right, so let's talk about the sexy class, the
Yes.
expensive class, and if we can afford it, it should be put in the water of obese diabetic.
You're right about that for sure. I think these class of drugs change the landscape of diabetes management because, like you were mentioning, like you've been using these drugs, I'm sure, for a while now, and every time I start this drug, about 8 or 9 times out of 10, the patient walks into the office with a happy face, and their life has literally changed. If there is one medication that they should take and they can afford, and they go out of the barrier of injection, they should be using these. And they started with Byetta, which is twice a day, and then Victoza once a day. Bydureon was once a week. And then the game changed when the two drugs came into the market, which is Trulicity and Ozempic. And many times, because of their great advertising budgets, the patients know about this when they walk into the door, but they're worried about potential side effects, which tend to be far and few between, but there is a risk of pancreatitis. And if you have a rare form of familial history of rare thyroid cancer called medullary thyroid cancer, we should not be taking this. But that is an extremely rare condition that we don't see very often. And then on the right side, we look at the drugs which are combinations of insulin and a GLP-1 agonist called Xultophy and Soliqua. In case you need insulin and a GLP-1 receptor agonist, then you can do that with one injection. So this class of drugs has literally changed the landscape of management of diabetes because they cause weight loss, which is what any patient with diabetes would want. And they eat less. Sometimes they even do not remember if they ate or not because of the appetite suppression. Sometimes it can cause some nausea. They have to be aware, go slow, don't try to push the food beyond their limits because there is a decreasing stomach emptying with this class of drugs. But they act on different areas. They act on the brain, they act on the liver, they act on the pancreas. So wonderful, wonderful class of drugs. But like you said,
Yeah, the cost is always a
cost is a
concern, but
problem.
yes,
Right.
if the cost is not, hopefully they become generic soon.
Well, you know how that goes, but yes, that'll be
Let's quickly talk, but let's not get too technical. Let's just cover them quickly. I know we are
sure.
going into technicality too much, but yeah, the SSG. These are also newer class of drugs, and they're indicated not only in diabetes and heart failure as well. So, you want to briefly touch on that, Venkat?
Sure. Yeah, these three would be the other, especially the Jardians and Farxiga have been shown to improve cardiovascular outcomes and renal outcomes. So right now, we never had drugs which can improve outcomes. Always the goal was glycemic control, get the sugars under control. But now we're focusing on how to prevent heart disease, how to prevent stroke. We want diabetes control, but we want drugs also to extend the life of our patients, to have them lead a quality life without complications. So these drugs, again, if they are affordable, would be excellent choices if we don't want injections, to take these oral pills to improve your outcomes and glycemic control, and have some blood pressure control and weight loss also on top of that, although they're not indicated for that.
Yeah, I think we're going to see, in near future guidelines changing. For example, patient with diabetes and chronic eye disease, which is a common combination, we're going to start seeing more GLP-1 agonists start using, if they have that combination. And then, as you pointed out, with heart failure, with chronic kidney disease, that's SGLT2 inhibitors, that's going to be standard of care as the costs start coming down. And now we have more competition in the classes as well. So that will help as well. So, yeah, I think it's very exciting what's on horizon for diabetes. Let's talk about
Absolutely.
insulin. Let's just switch quickly because we spend
Sure.
a lot of time on medications. So
Right.
the insulin comes in different class. We got long acting, we got short acting and fast acting. Then we got the combination, the 70-30, 75-25. Then we got different delivery mechanism, the old fashioned syringes and needles. And then we got the fancy pens with tiny needles. And then we got different sensors and pump. Do you want to combine all that and give a brief synopsis?
Yeah, I think probably I would say that there is a newer, extremely longer acting insulin analogs, which is very exciting, and some drugs, their delivery systems are getting so good that in the future, near future, we should probably be seeing an insulin which will work for a week. Now, insulins are working for 24 to 36 hours. Came from 12 to 24 to 36, almost 32 to 36 hours. And then, like you said, the short acting and the combinations in the right frame of mind. But maybe just touch a little bit on the sensors and how that is changing again the landscape. I would say GLP-1 is GLP-2s, and then the CGM sensors would probably be the next one in terms of the shift in the paradigm. So three different ones we use: the Medtronic on the left, Guardian sensors, and then the Freestyle Libre, which is very probably easily available, and then Dexcom. The one I'm showing there is G7, which is yet to be in the market. That's the latest one. The Freestyle Libre 2 is in the middle. For 14 days, you change it every 2 weeks. The Dexcom you change every week. But whatever ones you use, they will really help, and they're really helping tremendously. Because the pain of finger sticks is probably the most painful thing for many diabetes patients, even worse than taking insulin. And they are really, really pleased to see in the right coverage that these are covered. And then below that is the three different pumps, and the Medtronic on the left, the Omnipod, which is the tubeless pump, and then the tandem Control IQ with the Dexcom G6 being the latest pump. So these are for mostly for our type 1 diabetes patients and for some type 2 diabetes patients which are poorly controlled.
Yeah, so I think CGM is revolutionary. Or CGM stand for continuous glucose monitoring, and the only caveat is that if you are on more than 3 injections, so the insurances are giving a little bit hard time because they're
They are.
expensive.
Right.
But it's a game changer for someone who's on insulin and take more than 3 injections, because they don't have to prick your finger, as you rightly said, and then they can just wave the magic wand and they see the number right there, and they had a big bowl of french fries or popcorn with butter on it, and they say, shit, 300.
Yeah,
So
that's right.
uh,
It changes behavior. That's right. That's
yes,
the most important thing. It changes your behavior instantly because there's instant feedback.
right. And for physicians like you and me, once they bring the data, that's a gold mine. You can see what time of the day they had hypoglycemia, how much they're staying in the target. Before we get to the 3 month milestone of A1C, we have beautiful data in between that 3 months. So I think if the insurances approve it, the CGMs are fantastic for patients
Godsend.
using insulin.
They're godsend. And also the families. I mean, I have a patient right now with Down syndrome, and her grandmom takes care of her, and she can see what's going on real time wherever her granddaughter is, and so that really has changed the patients and families' lives.
Right, and we can access their data remotely as well. These are Bluetooth enabled devices, so which
Right.
can be used as remote,
Monitoring,
kind of
yes.
monitoring setup. So that's going to be revolutionary for patient care, as we're getting paid for telehealth visits and the remote monitoring devices. So I think they are fit in very well with that kind of care in future.
Absolutely.
We didn't touch on the a more fancy stuff, the pancreatic transplant, which is more esoteric, but more for people who have kidney failures with primarily type 1 diabetes, some early type 1.5 diabetes. But yeah, that's out there as well, but not as common. Just for completion's sake, I mentioned that.
Sure.
Anything exciting you want to bring up other than the CGM, GLP-1, SGLT2 inhibitors we talked about?
I think, for those, and the prevention of type 1 diabetes is a very, very progressive field. How do you identify people at risk for type 1 diabetes and enroll families, and how do you prevent that is a area of research. Islet cell transplantation, and that's also an ongoing experimental area. So yeah, a lot of and then different forms of administration of glucagon, inhaled glucagon. The inhaled insulin has been on and back and forth in terms of how it affected us and how it's useful. But that's also something to keep an eye open.
There is a question here from Mark. He's saying, can diabetes be controlled with diet alone? I'll take a crack and then you can correct me. I think
Sure.
depends on where you at with the diabetic spectrum. As we just alluded to, diabetes is a big spectrum, and you could be pre-diabetic, you could be early onset diabetic. Your A1C is hovering around 6.5, 6.7, or it's 10. If your hemoglobin is A1C is more than 10 or 10, diet alone not going to do it. But that doesn't mean you should not do the diet. That diet is the first step you should do. And with the GLP-1 agonist like Trulicity and Ozempic, patients are realizing they're losing weight, and then they start you know becoming more active and exercising more, and the diet improves because they see positive reinforcement of that class of drug. But diet alone is fantastic for pre-diabetic, absolutely, along with exercise. But as the sugars start going up and your insulin resistance start increasing, diet alone maybe not the only modality, right?
Sure, I think, yeah, absolutely, that the type of diabetes you have, make sure you don't have the type
Type 1.
1.5s or 1
Yeah.
or 1.5s we talked about. You can look like a type 2, but you
Mhm.
might not have type 2. So make sure you're not one of those by getting the testing appropriately in the situation. The second thing, like you mentioned, where you are in the duration and the stage of the disease. But what is very important for me to probably highlight is the initially when you are diagnosed with diabetes, there's a lot of glucotoxicity, so and lipotoxicity. So your pancreas is in a shock. So I would not focus on what I'm taking. I don't want to take any medications. I want to do a diet at that point, because no matter what you do, your pancreas will not make insulin for a period of time. So you shouldn't. I ask my patients to get over that. Take the whatever is required, do the diet, exercise, and medications, bring the sugars down, and let the pancreas heal. And once it heals and starts producing insulin, you will see the change, and you'll feel better, and you'll back off on all the medications. So the answer to the question, yes, but not immediately. So eventually, yes, but like you said, you have to go through the phases of correction the toxic situation first, and then stop the medications later on potentially.
Let's just wrap up, Venkat. I know we spend in details, and thank you for being so detailed, because
Absolutely.
you can do a whole fellowship on diabetes.
Right. Absolutely. We
And
try to
we
cover everything in 1 hour.
we try to cover it in a very short period of time. Well, let me just bring up a few things which we do in primary care. I'm pretty sure you do at your end too. If you're diabetic, make sure you get annual eye exam.
Right.
So that's part of the care. We covered medication, lifestyle. Let's uh, focus on what else we should do if we are diabetic. So annual eye exam is critical, because even you are pre-diabetic, you may start seeing changes in your nerves, which is neuropathy, or in your retina. even before you become diabetic. So, it's critical that once a year when you go to see your ophthalmologist or optometrist, and if you're pre-diabetic or diabetic, make sure they dilate your pupil, not just, just cursory exam, but dilate your pupil, look at your retina, and that can save, retinal hemorrhage, blindness down the line. So very critical to emphasize once a year annual eye exam, or more frequently if you have unfortunately developed diabetic retinopathy.
Absolutely.
So that's one. And then the second end of the spectrum, from head we go to foot.
Right. Most
Like,
important part. Yeah.
most important. If you don't have that, then it's a very big handicap. So
Right.
you look at your feet. A lot of folks who have diabetes for extended period of time, even pre-diabetes for extended period of time, they can get neuropathic and they lose sensation of touch and pain at the bottom of your feet. And that part of the skin, unfortunately, that part of the organ, the foot, is not very vascular. So God forbid you get a sore up there or some foreign body up there and you're diabetic. No matter what we do, sometime it won't heal and you end up getting amputation because of poor wound healing in diabetic, higher sugar, higher infection, and less wound healing. So it's very critical to moisturize your feet. Look at your feet twice a day. You know, think of your feet as your girlfriend when you're young. You bring roses to your girlfriend. You bring chocolates. So bring moisturizer to your feet twice a day. Look at it twice a day. Make sure there's no sore. And then get an annual foot exam, either at your primary care office, endocrinology office, or podiatry office. But get an annual foot exam to make sure you're not getting neuropathy, or if you're losing hair in your legs, or the feet is getting cold. That's the other aspect of diabetes. You get more circulatory issues or poor circulation. So very important to get them addressed early on. And diabetes can cause serious circulatory issues. So examine your foot, touch it, see if it's cooler, or you're losing hair on your skin. These are all telltale sign of the circulation not being good. So get that looked at too. Anything else you want to add to annual preventive maintenance in addition to the foot and the circulation and the eyes? I think we're having a technical difficulty. I'm not hearing you. I think you disconnected yourself by mistake.
Can you hear me now?
Yeah, I can hear you now. Thank you.
Sorry about that. So yeah, I was saying, looking at other things like aspirin use in the right setting, if you are a cardiovascular risk, of course, controlling your comorbidities like cholesterol, blood pressure, skincare is very important, and because that tends to be a big problem in many of our diabetes patients, and mental health, as well as back pain, and these pain issues are really huge in many of our diabetes patients. So looking at those kind of things, and in the right setting, maybe even looking at cardiac evaluation, your risk of cardiovascular disease, talking to your primary care doctor about whether you would be a good candidate for identification of one of the cardiac risk scoring and other issues. So those would be the main things. But foot, feet, and eyes are absolutely critical for every diabetes patient.
We missed on one area, which I know you're a big fan and I'm a big fan, is to get help from dietitian.
Right. We are not
And
dietitians, by the way, right? So professionally, we need advice from them for sure.
right. So if we can make them part of the team approach, especially when you're newly diagnosed or you're struggling with controlling your sugar, it's very difficult, unfortunately, with insurances to get a dietitian on board, except
Right.
for, if it's 10-hour class or something. I wish the insurances are a little bit more liberal with, getting dietary consultation. I think we'll have better
Yeah,
outcomes.
absolutely.
But that's a challenge. But if we can access them, I think dietitians are fantastic resources in maintaining food diaries and helping stay on the program and adjusting, their day-to-day dietary, what they're consuming, and improving that. So I think
Absolutely.
dietitian is a important piece of team approach.
Absolutely. Diabetes education by a certified diabetes educator and a nutritionist and a dietitian as part of the team is critical. And I think, like you said earlier on in the disease, if they can get that 1 hour class, and like you mentioned about the insurance coverage and those barriers, if they can be crossed, and that is critical in terms of not only type 1s, but type 2 diabetes patients also. They just become changed patients once they get that education, the detailed education about a meal planning, and their eyes suddenly open. No, I didn't know that was bad for me. I didn't know I was eating this bad. So the devil is in the details because it's part of our life. It's part of what we do every day. So you can just have a 10-minute consultation with your doctor and try to change your life. It's very, very difficult, isn't it?
All right, let's summarize. I'll give 5 points I learned from you, and you tell me if I missed something. So
Sure.
number one is early diagnosis. If you symptomatic or you have family history, please get it checked early, and make it part of your annual physical to get your fasting sugar and A1C. Number two is diet. What we give ourselves is who we become. So consuming less processed food and fast food, and consuming more fiber in your diet, more plant-based diet, more Mediterranean diet, whether you're diabetic or pre-diabetic or gestational diabetes, or just want healthy lifestyle, will help you. Number three, adding a little bit more physical activity, in this COVID era where everyone is using screen time, whether we are children or office goer, we are, so put an alarm on your computer, maybe every 30 minutes, every 15 minutes, take a break and have a sip of water, and take a walk. Number four, if you've been diagnosed with diabetes, um, just understand it's not a sprint, it's a marathon. Don't get overwhelmed. Follow the instructions of your physician, whether endocrinologist or primary care, or diabetic educators. Stay on course. And last not the least, look at your end organ damages, which can happen. So see a ophthalmologist or optometrist, or see your endocrinologist on regular basis, or physicians, allied services, to make sure you're not getting any complications. And if you catch them early, for example, you mentioned coronary artery disease, or atherosclerosis of the abdominal aorta, like abdominal aortic aneurysm, or any part of the body could be affected by the calcium buildup and hypercoagulable state of diabetes. So if you can catch it early, your outcomes will be better. And other than that, I think you can add anything else I missed.
No, no, absolutely. I was going to get very non-technical here at the end. I was going to say the three things I would like to highlight is prevention, obviously, is better than cure, applies to this more than anything else, because once you get it, it can be a very, very difficult process. Number two is hope. Don't lose hope. I think there is plenty of options available in case you need to be on medications. There's wonderful medications. So don't get despondent, and your life is not, you can lead a normal life as much as possible. Number three, I think, is community. I think we should involve more of your friends and family and all the virtual resources you can have, so that you can learn from others what everybody is doing and get support, because mental health and then coping is very, very important. So, in addition to all those three things, I would like to add those three things. And yeah, thank you very much.
Thank you, Venkat, and appreciate your time. I know we went overboard with our time
Oh,
allotted,
yes.
but it was such an important topic, and I felt that I let you have the stage. We didn't even cover the thyroid. I don't think we have time, so we'll bring you back, and we'll do the rest of the exciting parts of your endocrine practice later on. We'll put your you have office. I think you're more than one office, right? Do you want to talk about which locations you work from?
Yes, I have a couple of offices. One is in Pinellas Park and one in St. Pete. And so those are our two, Pinellas Park being our main location, and St. Pete is our satellite location. Yes.
Right. So, again, we'll put your address and phone number on our feed. So, if anyone looking for a good-looking endocrinologist who's very thorough,
You're very
Dr.
kind, Ranjan.
Budharaju, is the one to go to. Thank you so much, and appreciate your time.
Thank you.
Yep. All right, folks, we are at the end of our show, and appreciate you listening and being such a good supporter. And as Dr. Budharaju said, hope is critical. So stay hopeful and do the right things. Don't get overwhelmed, no matter what chronic disease you have. Take one step at a time. With that, we come to the end of our podcast and webcast, and we do it once a month. Do tune in next month. We'll put in our topic and our speaker on our Facebook Live and YouTube Live, and you can see what exciting guests we bring. If you have something else in mind which you want us to cover, like one of you folks asked for us to cover diabetes, let us know, and we'll see if we can add to our monthly webcast. Ciao, namaste, stay healthy. Bye.